Hello people, in this video let us look at the complications of fractures. So the classification of fracture complications can be something like this: immediate complications, early complications and late complications. So based on the duration you can put it like that, or there yet another classification. Look at this. So you can classify as specific, that's local complications, and systemic complications. Okay, in this video let us look at the way that they have classified early, immediate, early and late. So basically this will tell you why you should get it treated early, right? So what are the immediate complications, guys, that can occur because of fractures? So immediate complication means it is something that is occurring at the time of fracture. So systemic and local, okay? So what can happen? Systemic, there can be a hypovolemic shock. Shock can happen because of bleeding, isn't it? Hypovolemic. Basically what will happen here? External hemorrhage or internal hemorrhage. Some hemorrhage will cause this, isn't it? So that is the systemic problem. This usually occurs when there is pelvis fracture or femur fracture, guys. There can be loss of blood greater than 1.5 liter, etc. How will you treat this? You'll have to have two large bore IV cannulas like number 16, number 14, right? You should give them crystalloids like ringolactate, and you can follow it up with colloids, and remember you'll have to give them the blood. Which blood? They're exactly cross-matched blood you will have to give, okay? So one of the immediate things that happen. So what they will do is, as such, you will avoid moving the patient. Basically don't move the patient much, okay? Don't move patient much. Do an emergency angiography, okay? And then you embolize the bleeding vessel so you can stop the bleeding, right? Now what we looked at was the systemic complication. Guys, this systemic complication of hypovolemic shock can follow, it can, the ARDS can follow this. The acute respiratory distress syndrome can be a sequel with a subsequent shock. So you need to know about this. So, but this is an early complication. So in systemic itself, we have moved on to early, if you notice. Right, and then there can be fat embolism, there can be deep vein thrombosis, pulmonary embolism, right? So all these can be some early complications that you need to know about. Okay guys, and there can be aseptic trauma, fever, septicemia, crush syndrome. All these are important, okay? So crush syndrome, if you can notice here, it is more like a systemic thing, but compartment syndrome is a local. You understand, right? Compartment is a local complication, whereas crush syndrome is a systemic complication. So now let us look at this ARDS, acute respiratory distress syndrome. They exactly don't know why ARDS happens, but they are thinking that there is some release of some inflammatory mediators, guys, which cause the disruption of the microvasculature of the pulmonary system. That is your lungs, right? That's what they have written here, of the pulmonary system. So what will happen? Early complication, right? After this fall, it's not immediate complication, early. There will be tachypnea, that is he will breathe fast, and there's a labored breathing. If you take an X-ray, you can see that there are lung infiltrates, diffuse lung infiltrates. There is less oxygen, right? Arterial oxygen will be less, and this person can go into cardiorespiratory failure and he can die. So how will you treat? You will give this person 100% oxygen and he can recover in 4 to 5 days. Did you understand, guys? So this person, as soon as he fell, he had systemic complication, that is hypovolemic shock. See, you're concerned more about the systemic, isn't it? Because it can cause death of the person. The local will come to. But hypovolemic shock, right? And then he can, as a immediate complication, you saw hypovolemic shock. Then as an early complication, there can be ARDS, acute respiratory distress syndrome, which you're treating with oxygen, alright? And then there can be fat embolization. Remember, this is a serious complication. Fat embolization syndrome is a serious complication. Whenever there is a major fracture, what happens, guys? When there is the fat globules can come out of the bone marrow, okay, and they can occlude small vessels, right? So imagine if there is a blood vessel which is occluded by fat, right? What will happen? It's a serious complication. So what can happen to the person? There can be some cerebral or pulmonary effects. Imagine if this blood vessel is blocked with fat, okay, which is a major thing. So what can happen? The person can become drowsy, restless, disoriented. He can go into coma, right? Or if there is this fat sitting here, right, and this fat is affecting the pulmonary system, okay. Now what will happen? So the patient can go into tachypnea, tachycardia, etc. So basically what will you see? Other symptoms because of a fat embolism can be a rash, especially in the front of the neck, there can be rash. In the axillary fold, in the chest or in the conjunctiva, there can be rashes. I think it's better to call it as a petechiae or something, isn't it? So this person can go into respiratory failure and die. Okay, but if it is to the cerebral part, right, then what can happen? He can go into coma. Okay. So basically they are telling you some things like what happens, some theories they have for this fat embolization syndrome. Basically there can be release of free fatty acids, guys. There can be release of free fatty acid, okay, because the lipase acts on fat, right? The lipase acts on neutral fat. There will be release of these free fatty acids, okay. This will induce toxic vasculitis, and that is followed by platelet fibrin thrombosis. So because of all this, now there is a platelet fibrin thrombosis. This is what will cause the embolization. This is one of the theories. The other theory is that there is obstruction of the pulmonary vessels by fat globules. This is what you saw. So it can occlude even either the pulmonary system or even the cerebral type, right? Cerebral, there could be a lot of drowsiness, restlessness, disoriented and coma. How do you know that this is fat embolization? Very difficult. They are telling you very things like a retinal artery embolization, and you can see that the sputum or the urine may have fat globules. X-ray may show that there is patchy pulmonary infiltration, snowstorm kind of appearance. There will be less oxygen saturation, right? Then what else? How will you treat this, guys? How will you treat a fat embolization syndrome? So you will have to give heparin, very good. Then dextran they are giving. Heparinization, that's what they are saying. Intravenous low molecular weight dextran. We'll just go with dextran. Okay, it is some low molecular weight. Focus, guys. Intravenous low molecular weight dextran. Okay, this is what you will give. It's called as Lomodex. And then you can give some steroids. Okay. Just note here, guys, specific treatment they are talking about is intravenous 5% dextrose. Okay, 5% dextrose with 5% alcohol. This is known to emulsify the fat globules, and it is used by some people. What they are talking about? Guys, they are talking about 5% dextrose 5% and alcohol 5%. It will emulsify the fat globules. That's what some people are using. Okay, so that covers fat embolization syndrome. It's a serious complication. We told you the fat globules will come out, and it will basically, the neutral fat by the action of lipase becomes free fatty acids. Those will cause vasculitis. There can be blockage of the pulmonary vessels or even the cerebral flow, and there can be coma because of that, or there can be respiratory failure, death. How will you treat? You will give that person heparin. You can give IV low molecular weight dextran steroids. You can also give IV 5% dextrose with 5% alcohol. Basically, this is known to embolize the fat. Now, let us move on to the next systemic complication here, which they're talking about in the early complications, DVT and pulmonary embolism, guys. So, are you ready to look at the next systemic complication? Guys, look at this. This DVT is actually a common complication they are saying, and it is caused because of the immobilization. So, if the person is immobile, right, what can happen? There can be venous stasis, and that can lead to the formation of a thrombus. So, deep vein thrombosis can happen, especially in elderly and obese patients. This risk will be there. And if this clot, this thrombus, deep vein thrombus, let's draw it here, is above the knee. See, I'm trying to draw something blue here. If it's above the knee, right, what happens is it is more life-threatening. Okay. Usually, this is not immediate complication. This is more like a early complication. You can recognize it in 2 days, and this embolism usually occurs 4 to 5 days after the injury. Guys, are you focusing? If it is proximal to the knee, we told you if it is proximal to the knee, it can be life-threatening complication. There's a Homan's sign which will tell you, you know, that whether there is DVT, but it causes pain, right? Pain, calf tenderness, so which is exaggerated by passive dorsiflexion of the ankle. This is not done, if I'm not wrong. It's not done anymore. That's what we taught in surgery clinicals. So basically, what will you see in these patients? Initially, there'll be leg swelling, calf tenderness, right? then it can lead to pulmonary embolism, right? Because of this thrombus. In this pulmonary embolism, what can happen? Tachypnea, dyspnea, chest pain, hemoptysis. So this is the dangerous part of it, right? So when it is in this stage itself, you should recognize it. You should see the risk for a pulmonary embolism because of the DVT. How will you treat this if there is something like this? You will elevate the limb. You will put elastic bandage. You will give anticoagulant therapy. Right now, let us say it has reached pulmonary embolism. What will you do? You will give respiratory support. Again, you will give heparin, right? Then you will do early fixation of this fracture, right? So you will have mobilization. So if the person is immobile only, he will get this venous stasis and thrombosis. So you will make sure that the person has some mobilization of the extremity. So you will prevent DVT, okay? So did you understand? It is caused by immobilization, which will lead to venous stasis. So then there will be thrombosis, DVT, where how will you know that there is DVT? Leg swelling, calf tenderness, there will be Hoffmann's sign, that is the calf tenderness will get exaggerated by the passive dorsiflexion of the ankle, right, which I'm not sure they will do, but anyways, after that few days what will happen, this DVT can lead to pulmonary embolism, which will lead to tachypnea, dyspnea, chest pain, hemoptysis, which is going to be again a serious thing, right? How will you treat DVT? You will elevate the limb, you will give elastic bandage, you will give anticoagulant, etc. Now, if it goes to pulmonary embolism, how will you treat? If it is pulmonary embolism, you will treat again with respiratory support, heparin, right? You will early fix the fracture. That is the prevention. How will you prevent DVT? You can early fix the fracture, internal fixation we are talking, early internal fixation of the fracture. Okay, so you will have active mobilization of the patient, right? So you can prevent DVT and prevent the pulmonary embolism. Okay, so we are done with the next systemic complication. So what and all have we looked at so far? We looked at immediate systemic complication and early systemic complication. In immediate, we saw hypovolemic shock. In early, what and all have we seen so far? We saw that there can be ARDS, acute respiratory distress syndrome. Then we saw that there can be fat embolization. Then now we saw that there can be deep vein thrombosis leading to pulmonary embolism. Okay. Embolism can happen anywhere. It need not be pulmonary. It can be even cerebral, etc. Right? So many embolisms we have already discussed. Okay. Now let us go to crush syndrome. Crush syndrome is what they are describing next in the textbook. So let's look at crush syndrome. So what is crush, guys? So let us say there's an earthquake. Okay. And there's a huge block on me like this. Totally crushed I am. Okay. So basically what happens? The muscles are getting crushed. So here you can see that image. They have shown this thing crushing the leg here. So what happens? The myoglobin has come out of the muscles, right? And there is hemoglobin. So now it has become myohemoglobin, which you can detect in the urine. Dark amber urine due to the presence of myoglobin. There is test positive for hemoglobin. So this is crush syndrome. So if it has come in the urine, from where did it come? From obviously from the kidney. So what will happen to the kidney? This will precipitate in the kidney. It will cause acute tubular necrosis, acute renal tubular necrosis. Okay. So did you understand what will happen, guys? So now this myoglobin has come, myohemoglobin, that has caused all this precipitation here, and there's tubular necrosis. So now what will you see after a few days after this tubular necrosis? You will see very scanty urine in these people. You will see apathy in these people. They're not so happy looks like apathy they have. And then what else do you see? They can even have delirium, restlessness and delirium they can have because of all this. Okay, this will happen only after a few days after this tubular necrosis looks like, right? So if there is a crush, what they will do, they will apply a tourniquet here. Okay, tourniquet, they will apply a tourniquet. They will apply here. Okay, and they will release it gradually, so that whatever these substances that are getting released into the blood, all this myoglobin, hemoglobin, myohemoglobin, that will come in small quantities. So they'll apply a tourniquet and slowly release it, so that these substances are released into the circulation in small quantities. And if oliguria develops, that is, this patient is having this urine, that means what? He is going in acute renal failure. So you'll have to treat acute renal failure. Okay, which they have not explained much here about how to treat the kidney, but understand that there can be a crush syndrome. Because during this fracture or systemic effect, you should understand, right? Now, what have you understood here? Crush syndrome is more like a systemic effect. From the fracture side, the crush, the myoglobins coming out of the muscles. Then there's myohemoglobin, which can precipitate the kidney, cause kidney necrosis, and there can be even delirium, etc. So the best thing what they're talking about is you apply a tourniquet here, which is proximal to that crushed site, so that you can make these substances enter the bloodstream in a slower fashion. And by chance, if there is already oliguria or the person is having decreased urine output, that means he is going in renal failure. Pay attention to that. Okay. So people, what are we looking at today? Complications of fractures. Very good. You have finished the systemic effects, guys. Look at the systemic effects. What are the systemic effects? You have immediate, early, and late. Systemic, they're talking about only in immediate and early. Immediate, you saw that there's hypovolemic shock. Early, what is there? ARDS, acute respiratory distress syndrome. Then fat embolization, deep vein thrombosis and pulmonary embolization, which they're talking there. Then crush syndrome. So you looked at 1, 2, 3, 4, 5 kind of systemic complications you have looked at. Okay. Let us look at the other two that they have mentioned here. Septicemia. See, if there is infection, right, there can be septicemia. There can be aseptic traumatic fever because of, here they're saying aseptic, not because of infection. Some aseptic traumatic fever can happen in these people. Septicemia can happen if it's an open fracture, if it's infected. So there are some other complications that you will have to write about the fracture complications, systemic ones we have finished. So here are all the systemic complications we have looked at. Now we will move to local complications. Okay. Local complications, guys. Local. So local can be again immediate and delayed kind of a thing. You can say immediate. You can say there can be as soon as this guy falls, what will happen? He can injure he can not just have the fracture, that is the bone or the parts affected with it. It can also happen that he can injure a nerve. He can injure a blood vessel. He can injure the visceral structures. Delayed local complications in the delayed, or you can say not immediate kind of a thing. There can be non-union. It may not unite, or there can be some delayed union very slowly, or there can be malunion, like it is united but it's wrong. It's not the way it's supposed to be. Infection. Infection which can lead to what? Osteomyelitis, pyogenic arthritis, right? That means there is some inflammation, right? Of what? Of the bone marrow. Pyogenic, some bacteria organism giving a lot of pus there. So all this can happen, especially in open fracture or in surgical sepsis, that is after the surgery there is some infection. Then you can have all this infection. What are the two ways of infection? Either you have fallen and there's an open fracture, or they did a surgery and aseptic conditions, and aseptic is good, right? So this is sepsis is a bad word. So there was surgical sepsis, right? So that led to infection. Okay. Fine. So you have understood local complications overall. Let's look at the details. Guys, actually local complications list is a little more big, not as small as we thought. Look at this. There can be injury to nerve, blood vessels, visceral organs, muscle, tendon, joints, all that you will write. There can be non-union, delayed union, malunion, infection, compartment syndrome also is there. Okay, then there can be avascular necrosis, shortening of the limb can happen, joint stiffness, Sudex dystrophy. This is the sympathetic dystrophy, isn't it? They can have Sudex dystrophy. Then we talked about some other contracture, not just shortening of the leg. There is contracture. Okay, and myositis ossificans. We have to look at what this is. And osteoarthritis we spoke of here. Pyogenic arthritis we spoke of. So did you understand that there are a few more words that we added just now? Compartment syndrome, avascular necrosis, shortening of the limb, joint stiffness, Sudex dystrophy, ischemic contracture, myositis ossificans, is it? Yeah, ossificans and osteoarthritis. Guys, osteoarthritis we have covered. So let's just remove this word. So did you understand? Joint stiffness, I think you will write anyways. Here you add just muscle, tendon and joint injuries. All this you can write. Okay.